Simon Brewster runs this with a rod of iron. He's going to cover the entirety of urology in the next hour. Simon, over to you.
Great. Thanks very much, Mark. Good morning, ladies and gentlemen. Sorry, my voice has gone. I promise it wasn't because I was out on the razzle last night. It's a great pleasure to run this session for BAUS on breaking news and updates. We have 6 subspecialist speakers to cover the important developments in their view that have occurred over the last year, and I'd like to invite them up onto the stage and take a seat on the rostrum there. First of all, we've got Mr. Phil Cornford, who's going to be talking about prostate cancer. Each speaker will have a maximum of 10 minutes, and then if there's some time at the end, we'll take some questions from the audience. So please, Phil, come on and start us off. Thank you.
Thank you very much, and good morning. There's been quite a lot going on in prostate cancer just since the last BAUS meeting, and not everything can be covered. I would say this is a personal view of what's been important, and overall I was really impressed about how much British research has changed things, and we'll see that as we go through. I've got a number of disclosures seen on screen. I don't think they really relate to what we're going to talk about this morning, but I have been involved with several pharma companies. There are a number of things to talk about. The new prostate cancer grade groups, the role of MR has been discussed a lot during this meeting, hyperfractionation for radiotherapy, the addition of androgen deprivation to salvage radiotherapy, and a whole list of new treatments for metastatic prostate cancer. So just starting with the Gleason Grading Conference run by the International Society of Uropathologists, there's always been a little anxiousness about Gleason scores when you decide that 6 is actually the least aggressive tumour you're prepared to notice on a biopsy. It causes a degree of confusion for patients, because what happened to 1 to 5? And there's always been some difficulty in trying to separate out what is the difference between a Gleason 3+4 and a 4+5. And as a consequence, these grade groups were recognised earlier this year, and if you go to an MDT, if you get pathology reports back, you'll have noticed all of a sudden grade groups are appearing rather than Gleason scores on your reports, and without doubt this will make it easier for patients to understand exactly how aggressive or otherwise their tumour is. And it may also help us work out which patients are safe to watch. There's been quite a lot talked about MRI during this meeting. I have to say that some of these slides were created before I realised how much was going to be in the meeting. Clearly the role of MRI it's been used in multiple parts of the pathway, and PROMISE is likely to change what happens in terms of practice going forward. And interestingly, a British study, there is a little bit of a suggestion that we don't do much research in the UK anymore, and you'll notice that there are several significant papers that have come from the UK. So the PROMISE study, as you'll be aware, enrolled people who needed to have a prostate biopsy and convinced them to have an MR scan first, to ignore the results of the MR scan, and then have a template biopsy followed by a truss biopsy, and then compared the results. And the MRs were scored And the higher the score, the more likely you were to find significant cancer. And for people with low scores, which makes a fairly small percentage, the ones, very unlikely to find significant cancer. And twos, you didn't really miss very many, just over 10% of those patients with a significant cancer were missed if you didn't biopsy the people with a level of H2. And we have got used to the idea that if you do an ultrasound-guided prostate biopsy, that is a good way of working out whether people have got cancer or not. And clearly this shows that that isn't really true. And more particularly, this study shows that the negative predictive value for significant tumours is high for multiparametric MRI. And that allows us to do this, which is to cut down the number of people who have a biopsy and therefore cut down the number of insignificant cancers that we see. Telling somebody they've got an insignificant cancer and they can have it monitored is a cause of significant concern for them and their family. The idea that you can have an insignificant cancer is quite plausible inside this room, but for the general public, it's really difficult to deal with. And this data shows that if we cut down the number of biopsies we did by about a quarter, we could then avoid overdiagnosis and still detect more of the significantly prostate cancers. The other big study that was presented at ASCO GU this time was the CHIP study. Lots of patients from our centres will have been put into this, and it compares two different hypofractionation schedules, either a 19 fraction or a 20 fraction course, and biochemical 5-year failure rates showed that a 60 Gray given in 20 fractions was as effective as giving standard radiotherapy. And that matters for the NHS because it frees up capacity for patients to have radiotherapy. It cuts down the number of trips that patients need to go to centres to have their treatment, and it allows an increased capacity for treatment. And that's likely to affect the way that radiotherapy is commissioned in the future. This was an interesting study because bicalutamide is one of those things that's sort of largely gone away, and it shows that if you gave androgen deprivation with radiotherapy for 2 years when you gave salvage treatment, that you had an improved overall survival. So the data is old because it's a mature study, and they looked at patients, randomized them between having 150 milligrams of bicalutamide or placebo for 2 years and standard salvage radiotherapy. You can see the inclusion criteria at the top. And there was an improvement in overall survival in this study and in time to metastatic prostate cancer. And you can see the follow-up is long. So for most studies, you never get any decent follow-up because you have a result far too soon. But this is really long-term mature data. And it will make people think about whether you should add in androgen deprivation at the time of salvage. You might argue that there were people who were who had more advanced tumour, or their PSA was higher than we might accept these days for treatment. But the overall group, just over 50% of these people had a PSA of less than 0.7 when they were included in the study. So there are a lot of relatively low-risk patients. It's not all people with high-risk disease. And lastly, there have been a number of new NICE approved treatments, we have seen a change in the way that treatment is available. A lot of drugs have come off the Cancer Drug Fund, and all these treatments have been approved for commissioning in the UK. And if you often think, well, nothing very much has changed in prostate cancer in a year, but all of these things have changed. And one last thing that is beginning to notice is that testosterone replacement. There was a very interesting paper looking at testosterone replacement in men who've had treatment with prostate cancer, and potentially in men who are being monitored. So we appear to know three things. Testosterone therapy doesn't increase the risk of prostate cancer if you replace it in men who are deficient. Men who receive testosterone after treatment don't seem to have an increased risk of recurrence, and it might even be safe in people on active surveillance. Thank you very much.
Thank you very much, Philip. That's wonderful. Without further ado, I'm going to now ask for Miss Jo Cresswell from Middlesbrough to carry on with bladder cancer. Thank
Morning.
you, Jo.
Real pleasure to be here. Love an opportunity to talk about bladder cancer. So we're going to have a whistle-stop tour through my eyes, if you like, over the last year. First of all, let's talk about sex and bladder cancer. We've known for a long time, I think, that the outcomes for women tend to be worse than those for men. Mostly we thought it was due to late presentation, late diagnosis, maybe even less aggressive treatment. But there's an emerging story, and I've illustrated it a little bit with this observation from the PLCO study. So this is a long-term observational study, many, many thousands of patients, and it suggests an association between taking finasteride and a reduced risk of bladder cancer. This is far from causal, but interesting. And there is a plausible biological mechanism through the androgen receptor, and I think we'll see a little bit more about this in the next few years. Let's move on to diagnosis. And of course, we still consider TURBT to be a treatment for bladder cancer, but for many of us, we know that this is part of a diagnostic pathway. So the CROWS study reported this year, this was randomizing white light cystoscopy, standard cystoscopy, and narrowband imaging. And essentially it showed that there was a little bit of improvement with MBI, but only for the low-risk bladder cancer cases. This is slightly different to the premise for the PHOTO study, which is blue light cystoscopy versus white light, which is focusing on intermediate and high-risk disease. So I think we'll see a lot more about optical enhancement for TURBT as we go forward. Remember, MBI, any of us buying new stacks and new scopes at the moment, we're getting optical enhancement as part of the package, so it's a click of a button rather than an installation. Let's stick with TURBT, let's look at guidance. The only thing I've picked out really from the guidance this year is an acknowledgement that a single post-op installation is predominantly useful for those with low and intermediate risk disease, and it doesn't really serve a benefit to the patient or economically to give it in high risk disease. And out of the 5 guidelines I've looked at, 4 of those are now recommending it just for low and intermediate risk. While we're on the subject of guidelines, we've had some nice posters this week at the bladder cancer paper session about the effect of the NICE guidance, which we looked at last year. And this looked at non-visible hematuria referral patterns and also discharge of low-risk bladder cancer patients. There are some caveats. There are some cases, of course, that perhaps don't do so well in this new era of guidance, but I think overall, the impression I got from the room was that most of us are reasonably comfortable with adopting this guidance, but I'm sure we're going to hear a lot more about this. Stick with TURBT. So one of the other dogmas that we've accepted is that we re-resect high-grade T1 disease. And generally in MDTs, I know it's the same in mine, if it's T1G3, it's an automatic. We do a re-resection. Now, this is a retrospective study, so it has weaknesses, of course, but it's in a very large group of patients, multi-centre. And essentially, if there's detrusor muscle in the initial TUR specimen, then re-resection may not be as essential as we'd once thought. However, if there is no detrusor muscle in that specimen, it's a must. So the possibility for the future is that guidance might change slightly so that we focus our resources on those without detrusor muscle in the initial specimen, get them a re-resection rapidly in 2 weeks, 3 weeks, 4 weeks, and perhaps for the ones where there is muscle present, that we could go straight to adjuvant treatment without dilly-dallying. Not yet in the guidance, but I think it may well appear in years to come. Right, the BAUS cystectomy data set. So we're going to be having the first reports from this year. The data will be published in September. Very basic data along the lines of the nephrectomy data set. We have about 80% of HES cases are captured by the data set at the moment. So any cystectomists sitting in the audience, and that includes me, we need to get our data in. We particularly want to see the complications data, the mortality data, as credible as possible. That's going to be a judge of our data set. We had a preview this week with 2 studies. Ed Jeffries and Claire Miller, both trainees, presented these. We looked at benchmarks for open surgery, what is the current standard, and we looked at volumes, centre and surgeon volumes. Interesting things to come out are that predominantly we are performing radical cystectomy in high volume centres, and most of the robotic cystectomies are happening in those centres. Obviously for the section of oncology, I want to advertise the November meeting. We're going to have a big focus on the cystectomy data set with an opportunity to find out from our membership what we'd like to see published in the future. We're looking at pelvic cancer in November. We're going to have a lot of things about pathways as well, and PROMs, patient-reported outcomes, and quality measures. So that's in November in Cardiff. Sticking with radical cystectomy. This was a poster at the AUA. I wasn't there, but I've heard about it. So non-muscle invasive bladder cancer that progresses to muscle invasive. We've always known this is bad news. This paper points out that not only is it bad news, these patients don't really respond very well to neoadjuvant chemotherapy. So this is a group where hasty surgical treatment is a must. Lots of stuff in the bladder sessions this week about enhanced recovery, optimising perioperative care for radical cystectomy. The Bristol group published their enhanced recovery pathway and what happens when you introduce robotic surgery to that pathway. And this mirrors the experience, I think, of a lot of series in the UK, whereby we are seeing the length of hospital stay reducing with the introduction of robotic surgery. And in their series, it went from 13 days to 8 days. This is a high-volume centre with enhanced recovery. The poster that won the prize in the bladder session this week was from Mr. Banerjee and his colleagues at Norfolk and Norwich about prehabilitation, which, if you don't know about this is about exercising your patients in the run-up to their procedure. And even if you only have 3 or 4 weeks to do that, as you often have for radical cystectomy, potentially it makes a difference. And they looked at the feasibility of such a study. I've got to tell you, the patients of Middlesbrough are thrilled at the prospect of jogging around the park before their cystectomy. Following me, of course. Robotic cystectomy very much remains topical. Shamim Khan and his colleagues have published the CORAL study. Very good study. They've randomised and shown it's feasible to randomise to different surgical procedures. We all know that's not easy to do in surgical trials. There was reduced morbidity at 30 days. One thing that's interesting is, of course, that laparoscopic cystectomy did very well in this study. I think that's further emphasis on the fact that an experienced surgeon can make all the difference, whatever the modality. I think Mr. Rimington's still in the audience somewhere. And the next chapter, I think, in this is going to be randomised controlled trials in the UK and the US, which are going to randomise for robotic cystectomy, intracorporeal or extracorporeal reconstruction or diversion. And that might be a turning point in this story. The return of immunotherapy. Hooray, BCG is back for a while. We are all able to access BCG from more than one source again, and that is a relief for us and our patients. However, the landscape the BCG shortages created has allowed some attention to be paid to some alternatives. And the alternative scene, as I see it, is as follows. Christine Gann performed a very nice series with the Guy's and St Thomas's group, and they looked at the Di-Stasi regime of sequential therapy, BCG and EMDA, and produced some very nice 2-year recurrence-free survival results with relatively good tolerability of this modality. It is not controlled, it is a series, but I think it does show that there are options that can challenge BCG. Another option that is a challenger, I think, is the chemohypothermia scene. And Fred Vitch's group from the Netherlands, they use the Synergo system, and they've shown some nice results compared to BCG. Per protocol, it does significantly better, chemohypothermia. Intention to treat, not quite statistically significant, but you can see the trend. Checkpoint inhibitors. Tom Powell's talk yesterday, very exciting, using the anti-PD-L1 and anti-PD-1 antibodies. Second-line metastatic after chemotherapy. It's already been used now in trials for first-line metastatic, adjuvant, and we're looking forward to seeing what it can do in non-muscle invasive bladder cancer. Getting a red light from Simon. Yes, boss? I'll just finish off by saying that there's lots of trials open. Every urologist in this room, I'm sure, can recruit to one of these trials. There's the contact numbers for you. If this is videoed, you can look back at the podcast to get them. They're all recruiting new centres. DETECT1 is urinary biomarkers in the haematuria clinic setting. If you're new to clinical trials, this is a good one for you. And finally, Genomics England, the 100,000 Genome Project, is using bladder tumour types in its biobank, and this will answer some of the questions that Maggie Knowles posed earlier in the week. Thank you very much for your attention.
Thanks, Jo. That's really good. We're going to stick to cancer and head up the ureter to the kidney now. Ben Chalicum from Guy's. Thank you, Ben.
Simon, thank you very much for the opportunity, and to the committee. I'm going to put my own timer on so I know where we are. I'm going to tell you a little bit about kidney cancer, what's been topical this year. Really, I think a huge success. I mean, of really I think the outstanding audit in the BAUS audit is the nephrectomy audit. It's been going now for, it's really established. We're looking at it in 3-year blocks, and we're getting take-ups of over 80%. So 7,000 nephrectomies, 350 consultants, 140 sites. And this is something that the Americans, I think, were also interested in. We're doing 16 cases on average per consultant, up to 133, but those of us working pretty hard, and 37 per centre. That's 86% of HES data from last year, and we're looking at being at least that this year. I'm very grateful to Sarah Fowler for sending me some of these slides of this year. But if we look at that just as a chart, you'll see that if we start talking about increasing numbers up to 50 per centre, perhaps, where that would impact, or 25 per centre. If you look at that per consultant, and people are talking about maybe 20 per consultant, actually, median of 16, we're almost, we're there. There are only a few very small volume consultants and small volume centres. What is more concerning, if you look at this from a trainee perspective, is that 90% are being done by consultants. Actually, SPR is only doing about 7% of nephrectomies. And pertinent to the discussion earlier about what would happen if people needed to remove a kidney for trauma or in a hurry. Partial nephrectomy, one of my areas of interest. We can see that from this data, you can look at warm ischemia time across the country and see that those of us doing it with the orange, minimally invasively, very respectable. For open, of course, more of a range, because a lot of that's with cold ischemia. So this is the straight off the press now. Cases including the audit, which is literally just finished accrual last Friday from Sarah's laptop. And this shows you that laparoscopy remains the preeminent way of removing kidneys. If we look at it by procedure, that we're still doing over a third partial nephrectomy compared to radical nephrectomy, which I think is another reason for us to be fairly proud of ourselves as a nation. This graph, this is my graph that I really wanted to have a little look at, which is the purple line is partial nephrectomy with the robot. First time, this country, this year, Robot is no longer a bit of an add-on. It is the main way that we are doing partial nephrectomy in the UK. And red line is open, and that's just gone. So they've just crossed this year, which is of interest that we've got 20 centres, I think, now doing partials. So using that data, and of course now the data's there, everyone can look at it and apply and get results out of it. Tim O'Brien and team have looked at nephron-sparing surgery across the nation, and with my BJUI hat on, I want to really push this great way that Procar has got of us looking at it in terms of infographics. So what this allows you is to look at the paper really in a very engaging way. And interesting food for thought here, 36% of people who have a small renal mass under the age of 40 have benign tumours. 18% of those have complications, 5% seriously. 30% of tumours that are smaller than 2.5 centimetres, all comers are benign. Maybe we should be biopsying a bit more. In terms of the volume distribution relationship, four procedures per consultant is the average for nephron-sparing surgery, 8 per centre. And 36 surgeons and 10 centres only did one partial nephrectomy. But that is now 3 years old, so it takes that sort of timescale for the data to come through. So thank you for the BJUI team for sending that on to me as well. Now, building blocks for kidney cancer. A lot of it's been focused on clear cell. Marston Linehan's group have got a great paper that was in the New England Journal this year, really comprehensively characterizing papillary renal cell carcinoma. What this has shown is type 1 and 2 are very distinct subtypes. That type 2 can actually be divided into 3 other subtypes. Like everything, if you look at it more closely, it's always more complicated than you thought. And what this has shown is that you've got MET alterations in type 1 quite strongly. In type 2, you've got a whole range of things, but that one there, CDKN2A, glamorously named, and something called CIMP or KIMP, those are the poor prognostic markers. So what does this mean? It means that the next set of drug trials coming on will allow us to target these areas, and so that's the real building block of that. Just in the last year, the ASSURE trial, do you want to give adjuvant chemotherapy, TKIs, after nephrectomy? No, it made no difference, so we're not doing that, and everybody should have now stopped doing that. But what should we be giving? Most people would have pazopanib perhaps in their units now, but cabo or cabozantinib is the one that is really emerging. People are testing that against everolimus, and again, difficult to ignore 2 or 3 big New England Journal papers this year. What does this do? It's a TKI, but it doesn't just do VEGF, it does MET and it does AXL, so it does multiple targets. And that has been compared to everolimus, and yeah, it's better. It's a great graph, but it's still 7.4 versus 3.8 months for people progression-free survival, which again is not the ultimate answer of the METEOR trial. And not everybody responded. In fact, only 20% responded, and you had a 60% chance of adverse side effects with those drugs. So that is not ideal. How about if you compare that with Nivo? And it's really interesting to see that that same drug is also being used in bladder cancer as it is in kidney cancer, and that's being tested against everolimus, and that has been found as a checkpoint inhibitor to be, of some use, but it's intravenous, whereas all the other ones are oral, and of course we know the impact that that has on our resources. So that, quite encouragingly, looking at 25 months, this is for overall survival versus 19 months for everolimus. And these are people who had a previous agent, so this is second line. So lots and lots of interest, and this is obviously going to take the next few years for all of this to come out. What is the batting order here? Which ones do we use? But if everolimus isn't so good for kidney cancer, how about using it for tuberous sclerosis? And there is now a license for using AML, tuberous sclerosis. Everolimus has been approved by NHS England as of June this month. Why? It's an mTOR inhibitor, it's the EXIST trial, and what they've shown is that 54% of patients who have AMLs with tuberous sclerosis will respond initially, and this is quite impressive, I thought. 81% will get a 30% decrease in size, and 60% get a 50% decrease in size. So lots of decrease in size, but no additional bleeding risk. So if you have these patients, you want to get them on this drug because it works, they don't bleed, and you may stop yourself coming in the middle of the night for a very nasty reason. How about cytoreductive nephrectomy? Well, the Americans have looked at that, and there's a huge, my friend Kwok Tran, who works at us at the BJUI, has looked at that. He's got the National Cancer Database. up, and he has shown 15,000 people had cytoreductive nephrectomy, and of course they were younger, they were more likely to be privately insured in the States, they were more likely to be treated at an academic centre. But despite that, they actually did better. They've been able to factor all of that in and show that there was an increased median survival if you had a cytoreductive nephrectomy 17 versus 7 months. So I think for patients who have got reasonable performance status, we probably don't do this enough in the UK. In the US, it's 3 out of 10 patients get it. For us, I would think it would be more like 1 out of 10. Finally, my legs are still tired. Please sponsor us and we'll do it again next year somehow. Thank you very much.
Thanks, Ben. That's super. Well done. Could I now ask Andrew Sinclair from Stepping Hill to present the annual update on andrology and the urethra? Thanks very much, Andrew.
Thank you. Good morning. Now, I've been asked to do this talk. I did this one last year. And what I did at the very beginning was I emailed all my colleagues within the sections to ask if there's anything that they felt that internationally it could had changed the way we should be practicing this from a general urology point of view in the UK. And for once, I'm pleased that everyone agreed that the answer was no. So I then decided to look within the UK. Okay, and these are areas that I think have changed or can change the way we practice things from a general urology point of view in the UK. You can see for the first time in a few years we haven't got Peyronie's disease up there, although there has been a lot of work done, and Ollie Kay's presented a very good discussion on Monday about this. Most of this hasn't translated to a change in clinical practice in the UK. Collagenase is still a big talking point, and although it's approved by NICE, the hold-up is the cost and the time commitments that go with that. So that, again, is not yet currently available on the NHS within the UK, although lots of people are doing this privately with variable success. So we are going to touch briefly on male infertility, male incontinence, urethral reconstruction, then our database, which has been going for the last 6 years, and then finally some patient information sheets, which will be up and running soon. So NHS England have been looking at some of the things that are applicable to reconstruction, and that's include penile implant and urethroplasty. But I've put this up on surgical sperm retrieval. I think these are, well, they're currently recommendations rather than specifications, and they're still going through the process. But I think there's certain things to focus on. First of all, that there's no point going through this unless the patient's already got confirmed funding for IVF. And one of the exclusion criteria is still a previous vasectomy. But I think the word that really comes out to me in this is that Asif Munir has worked very hard to try and drag this back from the gynecologists. And so part of the stipulations now is that it should be diagnosed by a urologist, which I think is all, I personally think is a good way to go. Moving on to the slings and the sphincter, again, this has been an ongoing debate for many years. The artificial urinary sphincter has been around for many, many years. It is recommended as the only treatment by NICE for male incontinence, and it is an excellent treatment. But people have been trying to find an alternative which is more minimally invasive and maybe doesn't require the use of a pump. And so they have tried many things, but more recently, over the last 5 or 6 years, we've become more focused on the sling again. The problem we have is that NICE are recommending it quite rightly to be used as part of a clinical trial. The problem what we were having initially was that, first of all, there wasn't a trial, and secondly, the slings were becoming a problem of their own success, in that people were coming specifically requesting a sling rather than a sphincter, and it's very difficult then to change people's mind. Paul Abrams and the team have worked very hard to get this trial up and running. It's called the Master Trial, where we're randomising people between the sling and the sphincter. It's been going for several years, and the recruitment has it's had its ups and downs. I think the difficulty we've had along the way has been equipoise, but now I think most of us are a lot happier randomising people. I think you can see here a plea from the trial team is that we do need to try and improve recruitment again. We're just slightly under the curve, although the trajectory is quite good. The summer months are coming up, so please can we keep aware of things. Things do tend to tail off then. We do need to recruit. This is a very important trial, and it's a very important trial within the UK, which we should be proud of. So we need to keep going with that. Moving on to urethral reconstruction. Well, again, as a group, I think we're all fairly happy with the procedures and the outcomes. The outcomes from urethroplasty in the right hands is very, very good. So all the work these days is moving along, trying to modify the procedures we've got to minimise the morbidity. And last year we spoke about this, which is the non-transecting anastomotic bulbar urethroplasty. There was a poster this week that modified this further, so that when you're doing an anastomotic augmented bulbar urethroplasty, you can now do this by sparing the division of the spongiosum. So it's all an evolving process, but really it's the same technique, just trying to improve the side effect profile. But when we go back a step, we see that actually the problem we have is that an optical urethrotomy is a very, very easy day case procedure with relatively minimal comorbidities. So people are opting for that. And we need to try and shift that. So there is this, the open trial, which was first of all set up by Rob Pickard and has now been taken over by Nick Watkin. And it was a very difficult trial again to recruit to, because people were sent specifically to discuss reconstruction, and then we were trying to take them back to doing ureterotomy again. But I'm pleased that it has recruited, it has closed, and we've actually met the randomizations that we were meant to, and we're now continuing to collect the data. The reason I've put this one in is because we are having a few problems with follow-up data collection. And the reason for that is that often patients are being sent back to their original place for follow-up. But our PROM data collection has decreased with follow-up. So if you do have somebody that's been sent back locally for follow-up in the open trial, then please could you make sure that they continue to fill in their paperwork, especially the PROMs. We're having difficulty with the allocated intervention data, so when we are getting randomised, sometimes that data is not being completed. I think the communication between the hospitals is the crux of this. We do need to make sure that if things are going on out with the reconstruction centre, then we do need to make sure we converse. And that's particularly important from the re-intervention point of view. So anecdotally, we think that the theory is that people with having repeat ureterotomies will be having a higher recurrence rate, but that will often be found in the local centre and then operated on, and sometimes we can miss that. So please, can we be aware of anyone that is in the trial that's been sent back and let the trial team know if there is a further intervention. The urethroplasty database, this was Steve Payne and Tony Mundy's baby going back 6 years or so. Now, this was being done before it had to be done, which I think needs to be commended. It was set up, and Steve in particular has spent a lot of time and effort making sure that this is usable and that we all do prepare our data. There have been some modifications over the years, and I think it's the group should be commended for working together to try and get this working. You can see so far we've had over 4,000 new patients enrolled with over 2,000 or almost 2,800 follow-up data collected. We've got 3-year and 5-year data that we can use for publication. But now it's being used for surgeons' outcomes. And it's based basically on the bulbar urethroplasty, even though that's only one of the many procedures we perform. That's the procedure that we all perform, and everybody else, we do sort of different bits off the side of that. We now have data that's been published from November 2015, and it does include validated PROMs. So we're pretty proud of this data set. This is just some of mine. Now, I'm relatively junior, so my numbers aren't massive, but I'm working within the group to improve that. But you can see that even with these small numbers, you're getting some useful information, and it's been very helpful from our point of view to see this. And then lastly, we're looking at the patient information sheets. Again, Katie Moore and Lawrence Clark, which are two of my colleagues in the North West, have worked very hard over the last couple of years, and before that, Steve Payne and Tony Mundy before that. Now, this has been a 6-year process to try and get these up and running, and often there's some hoops that need to be jumped through, and then once you've jumped through them, they change them in a different direction. But these are all almost ready to go. So we're going to be, or the team are going to be looking at these with BAUS in the next couple of months, and hopefully they'll be up and live online by the end of September, October. And I think from your point of view, from a general urology point of view, there's going to be a very, very good patient information sheet on general urethral stricture disease, and then urethral dilatation and optical urethrotomy. These other ones are really for those people, if you're going to send them off to a reconstruction centre, it may be useful for them to print it off so they can see it, so they have some idea of what to expect. Thank you very much.
Thank you, Andrew. That's excellent. Now, next up we'll have Darren Smith from UCLH talking about endoluminal endourology. Thanks, Darren.
Well, thank you very much. Like Andy, it's very nice to be invited back, and particularly so having given this talk last year, to have come out afterwards to meet my friend Richard Napier-Hemi, who said, you know, that was very good and everything, but you didn't mention anything about laparoscopy. And I said, well, of course I didn't mention anything about laparoscopy. I'm not a laparoscopic surgeon. I'm an endoluminal endourologist. So it's with particular pleasure not only being invited back, but being invited back specifically to talk about endoluminal endourology. So this is the very first meeting in which this has been officially recognised as a fledgling subspeciality. So what I'm going to whip through in the next however many minutes that it takes is a bit of the demographics of stones, an update on medical expulsive therapy, what I'm now going to call, borrowing an idea from Matt Bultitude yesterday, a paradigm shift for flexible ureterorhinoscopy and PERC, a little bit about stents, and then some follow-up and residual fragments. So stones are common, and we know that, and it feels busy being a stone surgeon. And the reason for that is that we're doing more. In the last 5 years, as you can see there, the number of ureteroscopies that we've done has gone up by 50%, and flexible ureterorhinoscopies up by 100%, and open stone surgery, well, I'm not sure who's doing that, only 30 cases in the year 2014 to 15. So as Ben Turney then concluded, treatments are going up, and of course this has implications across the board. Medical expulsive therapy, we had a fantastic debate about this yesterday between Sam McClinton and John Hollingsworth. This is quickly, because I showed this last year, it was hot off the press, which showed that in the SUSPEND series, there was 80% spontaneous expulsion, placebo, tamsulosin, nifedipine, it mattered not. With their very bold and we think very correct conclusion that there's really very little place for medical expulsive therapy, particularly in the small stone. And to some extent that is supported by this also large randomised trial out of Australia. Slightly different endpoint. SUSPEND was criticised slightly for its pragmatic endpoint. This was based on CT. And as you can see at 28 days, really no difference across the board, particularly in the small stones. And if you really want to hang on to medical expulsive therapy in your practice, then you need to be using it for bigger stones and not the smaller ones. So flexible ureterorhinoscopy versus PERC, and what you might call the paradigm shift. Ureterorhinoscopy is now bigging itself up to treat bigger stones, whereas PCNL is kind of miniaturizing itself down to treat smaller ones, and therefore there is some overlap. This is a meta-analysis comparing PERC against retrograde intrarenal surgery, flexible ureterorhinoscopy by another name, and of course it's no surprise that the stone-free rate with PERC is bigger at the expense of slightly greater complication rate and a hemoglobin drop. And when they did a sub-analysis in this, flexible ureterorhinoscopy against the minimally invasive PERCs, and we're yet to have a really good nomenclature for these. Of course, the stone-free rate, not as good as a maxi PERC, but maybe better than a minimally invasive PERC for a shorter length of stay. So they concluded that RIRS, flexible ureterorhinoscopy, should be considered the standard therapy for a stone of less than 2 centimetres until enough adequate randomised studies have been done. But maybe that bar is in itself too high. We get lots of data from CROES, the Clinical Research Office of the Endourology Society, and what they've looked at here is flexible ureterorhinoscopy for a solitary renal stone of up to 2 centimetres. No surprise in the main conclusion there that the stone-free rate is less good as the stone gets bigger, and as the stone gets bigger, the operation takes longer. Less than 10 millimetres, it's a pretty good treatment, 90% clearance in one operation. Really, you have to question why a patient would have a perk for a stone of less than 10 millimetres. In the bit that's overlapping between 10 and 20 millimetres, the quote there of 80% clearance actually was for stones less than 15 millimetres. And when you get above 20 millimetres, above a 2 centimetre stone, really the clearance with Flexi is poor, and that is the perk cutoff. The reason for that is based on the volume. We've seen this presented in various different ways. This is my way of thinking about it. This is imagining the stone as a sphere, and as you calculate its volume in 3 dimensions, you can see as you go above 15 millimetres, the volume of the stone starts to go up exponentially. So the reason that there's a difference is just based on maths, really, rather than technique. This says much the same, so I'll kind of whip over it in the interests of speed, except to say that for the minimally invasive perks, the operation time takes longer, and perhaps compared with MaxiPerk, all of those other advantages are as shown. Simon specifically said, don't show any science, but I have to do a little tiny bit about this because we do have to be logical. How small is small enough for a perk? We've got micro-perk, which is just a needle and a laser. I would call that high-risk shockwave lithotripsy because it involves puncturing the kidney, and that's where the biggest risk comes. And that's why I have to show this thing from J. Endourol just in February, that actually just putting a needle into a pig kidney showed a 30% reduction in its renal plasma flow. It was not then changed by dilating that up to 30 French. The insult is the needle. Talking of insults, patients don't like stents. I mentioned last year about the use of stents on strings in a study that was published in the BJUI, and of course then there's a few studies and then there's a meta-analysis, and the meta-analysis for this concludes that stents on strings, they're easy for the patient to remove. They mean that the stent will be in for less long, and that's good because it helps to reduce their morbidity at approximately 10% risk of early removal. So finally, on to the follow-up. One of the difficulties that we have within stone disease is that we don't have a really good definition of stone-free. Is it genuinely stone-free by a CT, or is it very loosely and approximately and totally not stone-free as less than 4 millimetres by a plain KUB X-ray? And probably we will see the definition of a clinically insignificant residual fragment changed to 2 millimetres, which this supports. This is just a study of follow-up after shockwave lithotripsy, and what difference does it make? If patients have got a stone of less than 2 millimetres, they all pass them, and none of them went to A&E. If they're between 2 and 4, if you change that to approximately 80% of them pass them, 20% go to A&E. And if it's more than 4 millimetres, only half will pass and half will go to A&E. So really a 4 millimetre fragment is a stone, and it needs to be treated as such. Thank you.
Thanks, Darren. I must say, endoluminal endourology is quite a mouthful. I might just call it stones in the future. Thank you very much.
I quite like endourology.
Yeah. Now, our last speaker for the morning is Miss Suzanne Beers. She's going to talk about female urology and BPH. She's from Cambridge, and she's on the podium now. Thank you.
Okay, good morning. So I think I'm going to start with BPH, and the real thrust and enthusiasm is for looking for alternative, minimally invasive and other types of options for bladder outflow surgery. There have been new guidelines from the EAU talking about the assessment of male urinary tract symptoms. They were published just last June. There's 2-year outcome from the Goliath study, some more interesting and later follow-up from Urolift, and new research such as the Upstream trial, which is looking at the role of urodynamics for before bladder outflow surgery, and also the water study and the new aquablation techniques. So starting with the Goliath study, this essentially is comparing monopolar and bipolar transurethral resection with high-power 180-watt green light laser systems. They've published at 6, 12, and now 2 months and now 2 years. And as you can see from the data, green light and TRP do equally well. They have significant benefit to improving symptom score, maximum flow rate and post-void residuals, whilst maintaining a low complication rate. The reoperation rates at 2 years are statistically the same. So with green light, it's around about 10% of patients, and with TURP, it's 7.5%. And both have similar reductions in PSA and prostate volume. At the moment, this study is showing that green light has shorter hospital stays, which has financial implications, and a shorter indwelling catheter time, although I think if this was comparing strictly green light with bipolar, I think they'd be more comparable. Going on to Urolift, this is a minimally invasive mechanism for opening up the intraluminal prostatic urethra to help men with bladder outflow obstructions, and at the moment it's targeted at men without urinary retention and without a median lobe. There have been 2 systematic reviews with 12-month follow-up now, showing that from baseline, Urolift can improve patients' maximum flow rate, reduce their post-void residuals, improve their symptom scores and quality of life, and most importantly for the patient, sexual function is preserved. NICE have got a technology guidance out saying this is cost-saving or at least cost-neutral, but this can be done as a day case and under local anaesthetic. The LIFT study has followed up Urolift now for 3 years, and it's published at 3 years, and there have also been abstracts at the AUA for 4-year data. So at 3 years, about 10.7% of these patients will require revisional surgery. But at 4 years, it goes up to about 13.6%. However, of that group, 4% actually had a repeat Urolift procedure. And around 7% require the implants to be explanted because of encrustation, which may be due to the learning curve and misplacement of the implants initially. And the BAUS16 study is actually a randomized controlled study comparing TURP against Urolift. Now, as you would expect, IPSS scores and Qmax are significantly better for TURP. However, quality of life reported by patients at 1 year is equivalent. Ejaculatory function is preserved in Urolift, but interestingly, between TURP and Urolift, continence rates and ED rates were similar. Going on to aquablation, this is a novel technique which uses a guided ultrasound, which is supported by a robotic arm, to produce a high-power, high-velocity jet of saline to ablate prostate tissue in a controlled way, and this does treat the median lobe. So Gilling has reported his first clinical trial of 15 patients. They found that prostate volume was reduced by 31%. There were few and mild adverse events. Most patients were catheter-free within a day, although a third required recatheterization. As you can see from the charts, at 6 months, there were significant improvements in IPSS score and Qmax as compared to baseline. And the water study is presently recruiting, which is randomizing patients to TURP or aquablation, and that's ongoing. So going on to female and functional urology, there's a more diverse range of things that have been coming up. So really heavily influenced by the worry about anticholinergic burden in the patients we're treating with overactivity, this study by Drake et al. Has looked at over 2,000 patients who have remained having an overactive bladder and incontinence despite being on a run-in of about 5 milligrams of solifenacin for 4 weeks. Those specific patients were then randomized to monotherapy with either low-dose solifenacin 5 milligrams or 10 milligrams solifenacin versus a combination of 5 milligrams of solifenacin, so the lower dose, and mirabegron 50 milligrams. And you can see at the end of the trial, which ran for 3 months, that the combination treatment was the most successful at improving complete continence. And the combination treatment compared to low-dose solifenacin alone was statistically significantly better at reducing incontinence episodes and micturition frequency, and the combination therapy was statistically significantly better at reducing urinary frequency as compared to solifenacin alone. And interestingly, whilst combination therapy had more side effects than low-dose solifenacin, it had the equivalent number or was slightly better as compared to solifenacin alone, and there were no episodes of urinary retention. The ALTAR study is something I'm going to watch with interest. I'm sure you'll appreciate in your practice as well, we have a large number of women with recurrent urinary tract infections, and multi-resistant infections are on the increase. This study is a randomized non-inferiority trial, which is multi-center, and it aims to randomize this group of women to either low-dose antibiotic prophylaxis for 12 months or treatment with methanamine hipurate. So methanamine is basically a bacteriostatic agent that works best in acidic urine. And whilst it can't actively treat infection, once infection has been controlled, it can help to sterilize the urine and prevent infection, with the benefit that it doesn't cause antibiotic resistance. So they're going to follow women up for 6 months with primary outcomes of looking at prevention of recurrent UTI, and then secondary outcomes looking at UTI frequency, antibiotic use, antibiotic resistance on these regimes, and quality of life for these patients. And then finally, this actually is data from the poster that won one of the best posters for the academic part of BAUS, and this comes from data that we've been collecting in the FNUU section for the last 3.5 years. So this is data from UK urologists operating on stress incontinence. The majority of patients are primary, with about 20% of patients having recurrent stress incontinence. The median number of cases per consultant is about 11, although you'll note the range is from 1 to 37. 91% of people reporting showed no complications or reported no complications in their practice. And this is undergoing further statistical analysis at the moment, but you'll see if consultants are operating on less than 6 cases, their complication rate at the moment is 2.6. If they're operating over 20, it's about 2.4. So this is an interesting and evolving part of this audit. And you'll see we're doing well. So we're achieving continence in around 86% plus, and we're improving patients' quality of life and their patient scores in 90%. Thank you.
That's wonderful. Thanks very much, Suzanne. Thanks to all the speakers. Now, we've got about 5 minutes, and it would be great if anyone wanted to ask a question at the microphone to any of the speakers about what they've talked about, or even something else, because they're all experts. While you're coming to the microphone, I'll just quickly go through some points. Phil's talk, I think the issue of stopping biopsying men who have a normal MRI is quite controversial, and we need to really think carefully about this, and perhaps have some more support from the full manuscript from Promise and so on. Before we make a decision about that. Joe's talk, I thought the prospect of abandoning re-resection for people who have normal muscle in their sample is very encouraging. It'll reduce the number of patients brought back and the number of patients potentially having a perforated bladder as a result of that re-resection. Ben's talk, the prospect of cytoreductive nephrectomy is certainly still very much on the cards, isn't it? And I think that you know it looks promising from that study you reported there. Andrew's talk, we need to recruit more patients for the master trial, and and Darren's talk, using stents on strings seems to be a good thing to do these days, as long as the patients are happy to pull them out themselves. And then Suzanne's talk, the aqua ablation. I hear there's quite a lot of bleeding associated with that.
Well, it's marketed as a heat-free new technology, but the surgeons that I know that are practicing it in our hospitals use rollerball diathermy, so I think that counteracts a little. Hopefully that will be included in a non-biased statement at the end when they finish the study, the water study anyway.
Fine, yeah, good. I mean, it sounds interesting. No one going to ask a question? Okay, would any of the speakers like to say anything additional about or ask a question to anyone else?
You didn't warn us about that, Simon.
Well, I didn't expect
we go now?
A couple of minutes. Right. So in that case, I'd like to thank the speakers very much and you, the audience, and have a good day and travel back. Bye-bye.